I'm Dr. Sheila Smitherman. I'm a neurosurgeon at Olympia Orthopaedics. I want to talk to you a little bit about your neurosurgical procedure today. Let's talk a little bit about your lumbar spine stenosis. Some patients come to see me because they have back pain that radiates to their legs, and it's because they have a medical problem called spinal stenosis. This can occur anywhere in the spine, and it's common to occur in the lumbar spine. This is partially because the lumbar spine is an area of our body that really carries a lot of load, and we use it in everything that we do. And that area tends to degenerate over time. And with that degeneration comes arthritic change in the joints, and that can create narrowing in the spinal canal. And narrowing in the spinal canal, if it becomes really narrow, can pinch the nerves that serve the legs for sensation and muscle function. And we start to notice that. And that can mean maybe we can't walk as far because our legs are painful. We go to Costco and it's hard to walk all the way through the aisles and finish our shopping trip. Sometimes standing in line at the bank, our legs start to hurt. And that can be a manifestation of lumbar spinal stenosis. Depending on your specific anatomy, some patients would benefit from a lumbar laminectomy. And some patients would benefit from a lumbar laminectomy with a stabilizing fusion. Let me show you what that looks like. In this case, the spinal canal is really narrow because of several different features of degenerative change. This is an MRI, as if the patient is standing, looking at the wall, and we've made a vertical slice through the spine. So in this picture, the belly is here, the skin of the back is here, and then the buttocks are down here. The vertebrae in the spine are these squares, and the discs that cushion between them are these stripes. The spinal canal houses the nerves that serve the legs for sensation and muscle function. And those nerves are these gray stripes floating in this white fluid. The diameter of the spinal canal from front to back should range in the order of 15 to 17 millimeters, which doesn't sound like a lot, but it needs to be at least that wide to facilitate space for the nerves and vascular flow to the nerves so that the nerves get normal blood flow and can communicate from the brain to the legs and back up to the brain. You can see here that the diameter from front to back shows a lot of white fluid and space for the gray stripes, which are the nerves. And up here it's the same, but in this region here it's really narrow. So those nerves are getting pinched. And that can result in radiating pain to the legs or a general ache or discomfort with very little standing or walking. And that's called neurogenic claudication. And that just means the legs or the muscles in the legs can become achy and painful with standing maybe even fewer than 5 minutes. Sometimes the patient can benefit from a surgery called a laminectomy, but sometimes the patient needs something more than that to stabilize a misalignment causing similar symptoms. So here you see a side view of the spine as if the patient's standing and looking at the wall, and that vertical slice is made with the belly here and the back here. And can you appreciate how the vertebrae, which are supposed to stack one on top of the other, here at L4-5, there's a misalignment, so it almost looks like a staircase. But that misalignment narrows the spinal canal where the white fluid and the gray nerves are traversing. So these gray nerves are having to pass through this really narrow space, and there's not enough room. So if you look over here at this cross-sectional picture, this picture is one taken as if the patient is lying on their back, looking up at the ceiling, and feet are coming out towards the viewer. And a horizontal slice is made through here, where the spinal canal diameter is sufficient. So you can see white space, and the little gray dots are the nerves that serve the legs. But take a look down here. This picture is taken through here, where there's no space for the nerves to traverse. So it's probably about 2 millimeters worth of space. And you can see there's no white here. There's no white space. So the nerves are trying to communicate to the legs and they can't. And so this patient has very little tolerance for standing and walking. Can't go to the grocery store. Can't stand up and stay in line at the bank. and mobility becomes quite limited, and then you get deconditioned, and then that situation spirals. So let me show you what surgery to decompress the nerves might look like. If you have spinal stenosis, but you don't have any misalignment of the vertebrae, chances are you could have a surgery called a laminectomy, where the spinal canal is decompressed, but you don't need any instrumentation, like I showed on the films earlier. This patient has no misalignment, but if there's narrowing of the spinal canal, then the surgery would be a laminectomy, where we bring you into the operating room. My anesthesiologist gets you off to sleep, and then my team and I will put you on your belly on the operating table so that I can get access to the low back, where these pointy things, which are the spinous processes that you can feel if you touch the midline of your own back, where there are my landmarks to make my incision. If there's spinal canal stenosis at multiple levels, then the incision spans whatever levels need to be operated. And the skin is opened, the muscles are moved aside to do the work, and that lamina is removed to allow for the spinal canal diameter to be made larger so the nerves can float freely in the spinal canal and communicate more normally with the legs. Once that surgery is done, I sew the muscles closed, and we get you back on your back and wake you up. Many patients will stay overnight one night. Some can go home the same day. It depends a little bit on the extent of that surgery. Once you've worked with our therapy teams in-house to make sure that you've practiced some good biomechanical movement techniques and walking and up and down stairs to mimic things you might do at home, then we can send you home. And I have you come back to the office for your 2-week postoperative visit, where we check on how things are going and arrange for your outpatient physical therapy to start getting active again. If you've had a lumbar fusion, it's because you had a misalignment like we saw in the MRI earlier, where in that case, L4 and L5 were not lined up properly, and L4 was shifted forward. And that shifting forward needs to be corrected in order to bring the bones back into alignment, to recreate the spinal canal where the nerves are traversing through, to create a normal diameter. And that allows the nerves to communicate normally with the legs. In order to keep the bones in appropriate alignment, I have to put in hardware, which is instrumentation like this, made out of titanium usually, or cobalt chrome. It's a non-ferromagnetic metal, which just means it won't set off the metal detector at the airport. And it's okay to get MRIs in the future. This hardware allows for the bones to stay aligned by lodging the screws into the vertebrae and then locking them into place connected by these rods here on either side. Bone graft is used from the laminectomy bone from your own body, which brings bone marrow progenitor cells that help make bone want to grow, to fuse those bones together. And I put it in between the vertebrae in the disc space in a little holder like this, which we call a cage, but it's just a hollow holder in which I can put your own bone graft to promote bone fusion. And that helps you to heal as quickly as possible. Usually it takes about 3 months for us to start feeling like I can let you do more normal activities. So you'll do physical therapy after that first 2-week post-op visit and on until probably 10 to 12 weeks post-op. I check on you periodically with x-rays to make sure that the hardware is holding onto the bones and that you're feeling okay and that your fusion is maturing. Some patients will wear a brace depending on how many levels need to be fused. And if I have you in a brace, usually at 3 months post-op, I can let you loose out of the brace and get on to more normal activities. Thank you for joining me today. Thanks for giving me the opportunity to teach you a little bit about your neurosurgical procedure. If you have more questions or want to come for a visit at the office, please call my office or visit the website at olyortho.com.